Next, we will be talking about secondary demyelinating diseases. So we will discuss allergic / autoimmune diseases such as ADEM, viral diseases like PML and HIV, and then go through a list of vascular diseases that occur with secondary demyelination as a result of vascular disease. So first we'll talk about toxic metabolic conditions with secondary demyelination. And here's a big list of the toxic metabolic related demyelination. Everything from osmotic demyelination through alcoholism, Wernicke, toxic lesions from underlying chemotherapy medications oftentimes, Wallerian degeneration, hypertrophic olivary degeneration, radiation changes, and this interesting entity called disseminated necrotizing leukoencephalopathy, which can occur with the chemotherapy as well. So first we'll talk about ADEM. So this is acute disseminated encephalomyelitis. This is classically a monophasic disease, but it can have recurrences. Typically the recurrences occur within 6 months of the initial episode. In terms of clinical factors, the patients who end up getting ADEM, specifically children a lot of times, have a higher risk of multiple sclerosis. There is some controversy as to whether this actually represents an initial case of multiple sclerosis that was misdiagnosed as ADEM, however. It occurs most commonly in children under the age of 15 years, and they typically have a history of recent viral illness, vaccination, or infection, usually within 2 weeks of presentation. So their common clinical symptoms with ADEM, typically patients have encephalopathy and fever, headaches and seizures. In my fellowship, I was taught that if somebody is thinking about ADEM, that the patient should have some supratentorial type symptoms or some neurologic symptoms related to the brain. So specifically, they should have encephalopathy, or they should have some confusion, that they shouldn't be perfectly mentating. There's typically a latency of 7 to 14 days. These patients may present with acute transverse myelitis or cranial nerve palsies. They can have optic neuritis, but optic neuritis is fairly rare in ADEM. They can also have acute cerebellar ataxia. The anti-MOG antibody, which we talked about before with neuromyelitis optica, is present in half of patients with ADEM as well. So it's not very helpful in terms of differentiating neuromyelitis optica from ADEM if you think about a neuromyelitis optica spectrum disorder. In the CSF, what you see is an increase in white blood cell count with lymphocytic predominance. The disease is typically treated with steroids, but the mortality rate can be up to 30%. With imaging, ADEM again has T2 hyperintense lesions with or without enhancement. It's nodular or ring pattern with or without peripheral diffusion restriction. So this is a pattern fairly characteristic of a lot of the autoimmune demyelinating diseases we already discussed. Compared with MS, ADEM lesions tend to be rounder. They're typically larger with more poorly defined margins. They typically involve gray matter nuclei with thalamus and brainstem involvement. You can have about a third of cases with spinal cord lesions, and most commonly ADEM spinal cord lesions appear as transverse myelitis. In the brain, ADEM can present as well in the subcortical white matter as well as the periventricular white matter and the deep gray matter. In children more than adults, you have involvement of the brainstem and the cerebral cortex. It occurs in adults, it more commonly infects the cerebellum and spinal cord than in children. Here's another case, 74-year-old woman with impaired mobility and cognition. She was very confused when she presented. What you see are these areas of very subtle, rounded regions of enhancement going into along the posterolateral thalamus, also along the perivascular spaces with T2 hyperintensity. This looked a lot like cryptococcus, to tell you the truth, but this patient actually ended up having ADEM. Here's a 71-year-old woman with altered mental status. This was another head scratcher. We initially thought this was infectious encephalitis. You see these areas of subcortical T2 hyperintensities, somewhat confluent with, again, these areas of enhancement, and this turned out to be ADEM as well. There was an involvement elsewhere in the brain in terms of deep gray matter involvement in this patient. Next, we'll talk about acute hemorrhagic leukoencephalitis. So this is a very rare, aggressive form of ADEM. I personally haven't seen it so far. I've only read about it. Typically, patients have death in a few days to weeks, and you see foci of hemorrhage and imaging. So these areas of hemorrhage on susceptibility weighted sequence are always present with acute hemorrhagic leukoencephalitis, but they can be present in a mild extended ADEM as well. Here's a quick summary from this article in terms of ADEM versus multiple sclerosis and NMO. The green being NMO, this orange is the ADEM, the yellow is the multiple sclerosis. So you see that transverse myelitis can be present, is an imaging feature of ADEM as well as NMO. Bilateral optic neuritis is seen in NMO and multiple sclerosis. Optic neuritis can rarely be seen in ADEM as well. NMO and multiple sclerosis can both be multiphasic, as we saw in our case presentation, in our case sample we already went through. And then there's CSF pleocytosis, which can occur both in ADEM as well as multiple sclerosis. Cases of ADEM typically involves patients less than 16 years of age. MS typically involves older patients, and so does NMO. So those are just some of the few considerations in terms of distinguishing the two. Again, encephalopathy, fever, headache, meningeal signs more common with ADEM and not really seen with these other entities. Okay. Let's talk about demyelinating diseases related to viral disease, and also we'll touch upon a bacterial disease with Lyme's disease. So first we'll talk about progressive multifocal leukoencephalopathy, otherwise known as PML. This is a demyelinating disease caused by a virus or a JC virus that infects oligodendrocyte. So this is associated with reactivation of the JC virus, and it occurs in the setting of immunodeficiency. Now this may be related to either immunosuppressive therapy, such as in the case of multiple sclerosis, transplants, chemotherapy, or it can occur in patients with immunocompromised status or altered immune states. It can be seen with AIDS when the CD4 count is less than 100, autoimmune disease, lymphoproliferative disease, myeloproliferative disease, sarcoidosis, and sepsis. On imaging, PML typically has variable distribution. It can be parieto-occipital, posterior fossa involvement, solitary, or multifocal. Differentiating between HIV encephalopathy from PML is important since both can cause confluent white matter lesions without much mass effect or enhancement. Something that's helpful in distinguishing these two is that HIV is more central and symmetric, and PML is more peripheral and asymmetric. It can involve the subcortical U fibers, which HIV typically does not. The typical form of PML, you'll see multifocal demyelinating plaques involving the subcortical white matter, including the subcortical U fibers. You can see enhancement about 10%, but 90% has no enhancement. It lacks mass effect, and you see it in patients with AIDS. So you have to keep that in mind as well as HIV encephalopathy. So here's a 47-year-old man. He has a history of sarcoidosis. He has right-sided face, tongue, arm, and leg numbness and tingling for the last 2 weeks. He's been on high-dose steroids and infliximab. So what you see is two different time courses. This was obtained in July. This is obtained in October. What you see is this T2 hyperintensity involving the subcortical white matter, as well as involving the thalamus here. And then there's no contrast enhancement on either of these images. And then he ended up having this follow-up about 2.5 months later, and you see how it's progressed in terms of the T2 hyperintensity. Again, there's no contrast enhancement. There's no mass effect really to speak of. So this was a case of PML in this patient. As we talked about with HIV encephalopathy, this occurs in about 15 to 20% of AIDS patients. This occurs due to direct infection of the microglia by HIV. It's associated with a lower CD4 count, longer disease duration, and older age in patients. It's also associated with brain volume loss. That's the most common imaging feature you'll see with HIV encephalopathy. Again, it has a similar appearance to PML in that it's multifocal T2 hyperintensity and it's patchy, but this tends to be diffuse, bilateral, and symmetric. This can be periventricular. And it's also important to remember propensity for tumor and other infection in PML before attributing something to just HIV/AIDS in a patient with this disease process. Again, it's really helpful to look for mass effect, contrast enhancement if you're thinking about tumor or infection in a patient with HIV/AIDS. When patients with PML have AIDS, they have better prognosis with heart therapy. This can be complicated by something called IRIS, which is immune reconstitution inflammatory syndrome. So in patients with PML and IRIS, you'll see enlarging white matter lesions of PML, and then you'll actually have the mass effect and enhancement, with IRIS, which you typically don't see with regular PML, and it may involve the gray matter as well when it's complicated by IRIS. We'll talk a little bit about Lyme's disease. I know there's a lot of times when you see nonspecific white matter dots and spots, and it's more than expected for age, you draw into question Lyme disease. So this is transmitted by a tick bite. It involves the transfer of this spirochete to Borrelia burgdorferi. It's the most common vector transmitted disease. Clinically, as you probably remember, it involves a target-like rash and flu-like syndrome with neurologic and cardiac anomalies that occur weeks to months later. The CNS involvement occurs due to the autoimmune reaction in about 10% of patients. And CSF, again, shows high lymphocytes and elevated proteins, so it's helpful. Imaging features of Lyme's disease include multifocal white matter hyperintensities with enhancement. It's fairly nonspecific in terms of imaging features. They're more common in the frontal and parietal regions. They may involve other regions, including the basal nuclei, corpus callosum, and brainstem. The key thing that I find helpful in terms of whether I'm going to be including Lyme's disease or not in my differential is I like to see leptomeningeal and cranial nerve enhancement, and that's a distinction from multiple sclerosis. Multiple sclerosis usually doesn't show leptomeningeal and cranial nerve enhancement, although it can rarely.